Our next speaker is Dr. Lisa Forman. She is a professor of medicine and transplant hepatologist at University of Colorado, where she remains active in clinical trials focusing on cholestatic and autoimmune liver diseases. Today, she's actually going to be discussing clinical pearls in viral hepatitis. Dr. Forman? Dr. Forman, and you may be muted.
Sorry about that. Can you all hear me?
Yes.
Okay. So thank you, everybody. I have no disclosures. So first case is a 45-year-old female with a history of hypothyroidism who presents with progressive fatigue, nausea, vomiting, abdominal pain for 2 weeks. ALT is very elevated at 2,500, AST of 2,000, bilirubin is 2, alk-phos of 300. She had a recent trip to Mexico. Your suspicion is pretty high for hepatitis A, and so you get a hepatitis A IgM, which is positive. She is treated with supportive care, feels great. 3 months later, her ALT is 40, AST is 35, bilirubin is 0.8. 4 months later, however, her liver tests are noted to be elevated with an ALT of 350, AST of 400, and a bilirubin of 1.4. So hepatitis A is an RNA virus that is spread via fecal-oral transmission and more often person-to-person in the US. The incubation period is 15 to 50 days, and most people present with the prodrome of anorexia, nausea, vomiting, pain, and fatigue. Within 1 to 2 weeks of these symptoms, patients turn yellow, especially the adults. The vast majority of the time, hepatitis A is a self-limited course with complete recovery, with 60% at 2 months and almost 100% at 6 months. But it's important to realize that up to 20% don't follow the typical course. And this patient was diagnosed with relapsing hepatitis A. So incidence of this is anywhere from 3 to 20%. The initial illness really mimics the usual course. These patients recover with improvement in their symptoms in labs, and then a relapse follows 1 to 3 months after recovery. This relapse tends to be more mild than the initial presentation, although the ALT can peak over 1,000. And 20% of these patients will have multiple relapses. It's important to note that during the relapses, the hepatitis A is detected in the stool, and so the patients are infectious. Mechanism of relapsing hepatitis A is unknown. Perhaps it's host-related with an inadequate antibody response, or perhaps it's virus-related, such as a mutation of the virus, but it's not well elucidated. Treatment is really supportive, and there's no role for using steroids. Another unusual variant of hepatitis A is cholestatic hepatitis A. The prevalence is unknown, but it's thought to be less than 5% of all patients with acute hepatitis A, and the pathophysiology is unknown. These patients present more with prolonged jaundice and cholestasis, with a bilirubin frequently over 10, an elevated alkaline phosphatase, but only very mildly elevated transaminases. And as with all cholestatic liver diseases, cholesterol is elevated, and these symptoms can last 12 weeks or more. I think for this, one needs to have a high clinical suspicion, rule out other causes of liver diseases such as a right upper quadrant ultrasound, checking labs to exclude other causes, and then checking another anti-hepatitis A IgM. Liver biopsy, cholangiography, however, is not indicated in most of these patients. Treatment is supportive. This resolves without any long-term sequelae. In patients that have quite a bit of pruritus, cholestyramine can be used, and there's very few case reports looking at the use of prednisolone or prednisone, which may decrease the bilirubin or shorten the course, but there's not enough data to recommend it routinely. Hepatitis A also may be a trigger for autoimmune hepatitis. Patients with hepatitis A will have their expected clinical and biochemical improvement, and then their labs increase within 3 months. And now the serologic and biopsy workup is consistent with most likely type A autoimmune hepatitis. This is relatively rare. It occurs almost entirely in women, and often these patients have a family history of autoimmune hepatitis. And what likely happens is that acute hepatitis A is unmasking autoreactive epitopes in patients with a genetic predisposition. And treatment is the same as you would with any patient with autoimmune hepatitis. Also, it's important to remember that hepatitis A can present fulminantly. It's rare. Fatality is unusual in children, but there are higher mortality rates in patients that are older than 40 years and those with underlying liver disease. When patients do present with acute liver failure, up to 50% of them will either die or need a liver transplant. But overall, fulminant hepatitis A as an indication for all liver transplants is quite rare. Hepatitis A is also associated with many extrahepatic manifestations such as leukocytoclastic vasculitis, toxic epidermal necrolysis, arthritis. They can develop kidney problems, optic neuritis, myocarditis, myelitis, and then it's also been associated with cryoglobulinemia and thrombocytopenia. There's also a threefold increase in the risk of aplastic anemia with previous hepatitis A infection. It's not thought, however, that hepatitis A is the definitive etiologic agent. In fact, in patients with aplastic anemia, the Hep A IgM is usually not present. So perhaps hepatitis A is a surrogate marker for another microbiologic agent that's transmitted in a similar way as hepatitis A. So in summary, I think we all need to be aware of the unusual manifestations of hepatitis A to avoid misdiagnosis and unnecessary testing. Treatment is supportive, and while fulminant liver failure from hepatitis A is rare, when it presents, transplant is often indicated. And the key, of course, is vaccination. Second case, this is a 55-year-old male who has a past medical history of cirrhosis secondary to alcohol and fatty liver, who had a deceased liver transplant 3 years ago, and he presents in clinic for his annual follow-up. His post-transplant course was remarkable for acute cellular rejection 3 months after transplant that was successfully treated with steroids. 1 year after transplant, he had an episode of CMV viremia, and this also was successfully treated. Labs during this visit were significant for an ALT of 98, AST of 69, a bilirubin of 1, alk phos of 135, a tacrolimus level that is normal at 6.5. So the differential diagnosis for elevated liver tests following transplant is broad and includes rejection and CMV, strictures, medications, vascular, and certainly recurrent NASH and alcohol. So in this patient, we checked a CMV PCR, which was 0. He had an ultrasound, which was normal. We increased his tacrolimus dose, and despite that, and having increased levels at 8.7, you see that his liver tests are still elevated with an AST of 98 and an ALT of 210. MRC was then obtained, and it did not reveal any strictures and stones, so a biopsy was performed. And the biopsy is significant for showing an expanded portal tract with this lymphocytic infiltration, which is consistent with moderately active hepatitis. CMV stain was negative, there was no rejection, and no steatosis. So with these biopsy findings, we checked a hepatitis A IgM, a hepatitis B DNA, hepatitis C RNA, which were all negative. We checked ANA and ASMA, which was negative as well. So we then checked a hepatitis E IgM, which was positive, and a hepatitis E PCR, which was positive as well. So this leads the discussion to hepatitis E. So hepatitis E actually stands for epidemic or enterically transmitted non-A, non-B hepatitis. It is a single-stranded RNA virus with an incubation time on average of 40 days. It can present acutely or chronically, and there are 4 genotypes. Genotype 1 and 2 are the ones that are responsible for human epidemics, and genotypes 3 and 4 are responsible for chronic infections most of the time. Hepatitis E is the most common cause of viral hepatitis worldwide, and the global seroprevalence is 30 to 80%, and in the US, only 6%. Hepatitis E, there are about 20 million new cases per year, of which 3.3 million are symptomatic, leading to 44,000 deaths. In terms of its mode of transmission, in industrial countries, It is primarily foodborne, genotype 3 and 4, with undercooked pork, deer, boar, rabbit, and shellfish. However, in developing countries, it's primarily oral, or waterborne, genotype 1 and 2 from contaminated water supplies. Vertical transmission has been known to occur. Blood transfusion can transmit hepatitis E, but there's only been one reported case in the US. And if you look at the donor blood pool, there's extremely low prevalence of hepatitis E RNA. There has been reports of it being transmitted via organ transplant and also potentially via sex. In terms of the diagnosis, I think number one, it's important to have a high suspicion of hepatitis E. In immunocompetent patients, the first step is to check for anti-hepatitis E IgM. And if it is positive, it certainly indicates either a recent or active infection, and it be confirmed by checking hepatitis RNA in the blood or the stool. In the immunocompromised population, again, you should test initially with the hepatitis E IgM. However, there's a high incidence of false negativity. And so if your suspicion is high and you get a negative test, the next step should be checking again for the hepatitis E RNA. It's also really important to know that although we talk about checking for hepatitis E IgM as well as hepatitis E RNA, these tests are not standardized and they can be very unreliable with a high degree of false positivity as well as false negativity. In terms of its clinical features, it often mimics hepatitis A. Most patients are asymptomatic or mildly symptomatic. It's self-limited. Symptoms like hepatitis A include jaundice, nausea, vomiting, malaise, abdominal pain, and fever. Extrahepatic manifestations such as neuritis, acute renal failure, and hypothyroidism can occur. And rarely, acute liver failure is associated with hepatitis E, with pregnancy, malnutrition, and pre-existing liver disease being its risk factors. And as we'll talk about, chronic hepatitis E is most commonly seen in patients that are immunosuppressed with organ transplantation, HIV, or underlying chronic liver disease. Overall mortality is 1 to 4%. What about hepatitis E in pregnancy? Well, this tends to be genotype 1 or 2 and a much higher mortality, up to 25%. Acute liver failure and mortality tends to be more common during the third trimester of pregnancy, and obstetric complications are not uncommon, including eclampsia, hemorrhage, stillbirth, and fetal viremia is present in 80%. There is some thought that exposure to hepatitis E early in life may reduce the risk of acute liver failure in pregnancy if later reinfected. And poor outcomes in pregnancy may be due to poor nutritional status and poor access to medical care. Chronic hepatitis E, this is being increasingly recognized in the transplant literature, and chronic infection occurs post-transplant. It is due most commonly to genotype 3. IgG at transplant, however, is only present in 13.5 to 38%. De novo infection can also occur, and it progresses to chronic infection in up to 2/3 of the patient. Risk factors for chronic infection include earlier infection and patients who are lymphopenic. And it can progress to cirrhosis in as little as 15 to 48 months. Reactivation of hepatitis E is rare. So if you look at this figure here, this is a patient who was transplanted. Donor liver biopsy looks good. At approximately 4 to 5 months after transplant, patient's liver enzymes were found to be elevated. Initially, it was attributed to acute rejection, so the patient was treated with steroids, and then ultimately a diagnosis of hepatitis E was made. And you can see here that at 1 year post-transplant, already there's histologic evidence and radiologic evidence of cirrhosis. How do you manage chronic hepatitis E? Well, the first thing is to reduce immunosuppression. And reduction in immunosuppression can lead to hepatitis E clearance by itself. If, however, there is no hepatitis E clearance, it's suggested to start a trial of ribavirin for 3 months. And this has an end of treatment response of up to 95%, but a sustained viral response that is only 64 to 78%. If patient relapse after ribavirin monotherapy, the next step is a 6-month course of ribavirin. And if hepatitis E is still persistent, then you can try pegylated interferon. There's been really no data that other treatments such as savasivir or zinc is helpful in the management of hepatitis E. The key to hepatitis C is prevention, avoid water of unknown purity, using good personal hygiene, avoid raw, undercooked seafood, meat, and pork products, and hunters should wear gloves while handling blood products. It's also just want to note that there is a recombinant vaccine for hepatitis E licensed in China called Hecolin, which is 96% effective at 1 year, but the WHO does not recommend it due to insufficient data. So in summary, for Hep E, it's under-recognized cause of acute hepatitis. It's increasingly impacting developed countries. It can cause both acute and chronic infection. I think one needs to consider it in patients with persistently elevated transaminases, diagnosed with Hep E IgM or PCR, and treatment is largely supportive, lowering immunosuppression and the use of ribavirin. Case number 3, this is a 35-year-old from Ghana who presents with an ALT of 180, AST of 165. He is Hep B surface antigen positive. His Hep B viral load is 1100. Hep C antibody was negative. Ultrasound looked okay with no evidence of cancer. And we checked a hepatitis D antibody, which was positive. So hepatitis delta is a defective RNA virus requiring hepatitis B for replication. So therefore, only patients with hepatitis B can contract hepatitis D. It can be co-infected, where hepatitis delta is acquired simultaneously, or superinfection, where it's acquired after being first infected with hepatitis B. There are 8 genotypes that are distributed geographically. Patients may be asymptomatic, acute, or chronic, and it is the most severe form of chronic viral hepatitis, leading to a more rapid progression to cirrhosis, liver cancer, and liver-related deaths. So here's just a figure showing how hepatitis D does require hepatitis B surface antigen. And this is what it looks like under the microscope, with the genome being over here. And this is the surface antigen on its envelope. 40 to 60 million people worldwide are infected, but estimates vary depending on risk factors and location. And the true global prevalence is unknown due to insufficient data and lack of testing. Modes of transmission is similar to hepatitis B. And populations at high risk include people who inject drugs, sex workers, men who have sex with men, hemodialysis patients, and patients with hemophilia. Patients that have co-infected, they will have acute hepatitis, of which 10% may be fulminant, 80% will recover, but chronic hepatitis D in 10 to 30%. Superinfection, 80% will chronic infection, and the majority will progress to cirrhosis and liver cancer. The course, however, varies by not only hepatitis D genotype, but by Hep B genotype as well. You can check serologies to differentiate between hepatitis B, hepatitis D co-infection, superinfection, or chronic infection. But just like with hepatitis E, the hepatitis D antibody and the hepatitis D RNA are not standardized, and nor are they widely available. Hepatitis D is associated with much more severe course versus hepatitis B monoinfection, as you can see in this figure. It also has been associated with a much faster progression to cirrhosis compared to hepatitis B monoinfection. There are many factors associated with disease progression, such as male sex, lack of antiviral therapy, and chronic infection. And low albumin, older age, high GGT has been associated with advanced fibrosis. Hepatitis delta promotes progression to cirrhosis and HCC, with HCC occurring within 10 years. And disease progression is not linear. And as with hepatitis B, HCC can develop in the absence of cirrhosis. Because hepatitis delta does not encode for any viral enzymes and it uses its host polymerases for replication, nucleoside tied analogs are ineffective. Pegylated interferon alpha is the standard of care, but SVR is rare. So treatment, really, once you make a diagnosis of hepatitis D, after you make a diagnosis of hepatitis B, is pegylated interferon for at least 48 weeks. If hepatitis B viral load is elevated, you can consider treating hepatitis B with nucleoside or nucleotide analogs. I'll skip this slide. Just want to end with the fact that there are a number of therapies in clinical trials right now, including Mercludex, which is an entry inhibitor, pegylated interferon lambda, and prenylation inhibitors such as lenacapavir. So in summary, hepatitis D is underdiagnosed. Hepatitis D has poor testing frequency and low linkage to care. In my opinion, all hepatitis B patients should be tested for hepatitis D by antibody testing. You need a rapid test, however, on the global market. The best current treatment is pegylated interferon, and efforts really are needed to reduce the global burden of hepatitis B. New therapies are needed that are safe, effective, and also affordable. And the key is prevention. And the first step, of course, is hepatitis B vaccination. Thank you.
Excellent. Thank you, Dr. Forman. That was a wonderful talk. If you could unshare your screen.